putting on this symposium. And, you know, when Mark first contacted me, I was actually in the Ukraine where we were teaching scientists about monitoring for infectious diseases. And I think I told you I was in the Ukraine, which is kind of crazy given what's going on right now and what's going on for my colleagues over there. But, you know, I hit times where I feel that I can't convince anybody that this is important. And so Mark's email to me about their data and the work that they'd been doing just came at just the right time, where sometimes you need moments of motivation that somebody really does hear what you're saying and care. And so thank you, and thank you for doing this. And this is just, it's wonderful to be here. And so I'm going to be speaking today about sex differences in the outcome of viral infection and vaccination, with a bit of a focus on influenza, but where I can pull in data, other systems that we've worked in, or data from other viruses or vaccines, I will, in an effort to kind of speak to the universality of some of the differences that we study in the context of influenza. Okay, so let's start with big picture. So this particular slide or table is, these are all data from humans, not from my lab. I think the only contribution I have made is for hantaviruses, which I worked with in another life. But so what I like to use this slide to illustrate to you is that the outcome of viral infections, as the title suggests, do in fact differ between the sexes. And as a general rule of thumb, when we look at things like the prevalence of infection, which are indicated by these P's, the intensity of an infection is indicated by these I's, and so the prevalence of infection, just for anyone who doesn't work in infectious diseases, is just the proportion of individuals within the population who are infected with a particular virus. And when I refer to the intensity of the infection, we're talking about the viral load in this case. Okay, so the amount of virus within a particular individual. And so when we look at the intensity of infection or the prevalence of infection, the general rule of thumb is that males do worse. Okay, you tend to find higher prevalence of infections among men. You tend to find more virus in men. Okay, and so great example, a lot of beautiful hepatitis, both hepatitis B and C work coming out of different laboratories around Asia that have really done a nice job characterizing this, characterizing that being male is one of the biggest risk factors, not just for being infected with hepatitis, but actually for progression to certain hepatic cancers. So I know there's a lot of interest in this room in cancer. HIV is another great example where the intensity or the viral load for HIV is consistently shown to be higher for men as compared with women. And so when we look, though, not just at the intensity and prevalence of infection, but when we look at who gets hospitalized with severe disease, which are indicated by these Ds, or when we look at who dies as a result of infection, what we find is that in many cases it's women. So this is true for HIV. So when you match men and women for HIV viral load and look at progression to AIDS, women progress about twice as fast as males. When we look at influenza, which is again what I'll be focused on a bit today, and we look at hospitalization or rates of hospitalization, in many cases it's women who are being hospitalized a bit more than men. And we'll talk about ideas about causes for why there are these differences, and I do think they're complex. And I know that the center here focuses a lot on not only the biological differences, which as a biologist I am going to heavily focus on today, but I can't leave out that gender differences in exposure, gender differences in access to healthcare, access to antivirals within a specific amount of time that they could actually help, that these are all factors that can and do play fundamental roles in some of these differences that we see between males and females. And that's why on my slide you don't see on this table, I'm not saying sex differences, I'm not saying gender differences, I'm just saying differences between males and females, because I believe that both are playing fundamental roles in explaining these differences. But I am in a biology department, and so I'm going to speculate about and utilize some of our animal models to hypothesize about the role that biological differences may play. So again, we work heavily with influenza viruses, and just to kind of show you a little bit of epidemiological data, whenever I make this statement that females suffered more severe disease during the 2009 H1N1 pandemic, I get a lot of raised eyebrows. I think it was pretty well publicized and well accepted that during the 2009 pandemic, it was unique, as many pandemics are for flu, in that it struck otherwise healthy young adults. So I would argue that these are adults 16 to 45, adults of reproductive age, if you will. So very different from what we see during a seasonal epidemic, where it's the very young, so children, or aged individuals who are suffering more disease. So again, making it a bit unique. I keep losing my. We heard a lot about pregnancy. Absolutely, pregnancy was a significant risk factor for more severe disease. But one thing that received very little attention, despite the fact that the WHO hired me to write a report on this, which is freely available online at the WHO, just a little plug, that being female was in fact considered a risk factor for more severe disease. And what was really interesting, and so this is published in the Canadian Medical Journal, Canada was just a standout country. And not because I think there was something highly unique about the pandemic in Canada. Canada has one of the most aggressive and successful women's health initiatives that I am aware of anywhere in the world. And they have been so successful at getting funding agencies to require that investigators analyze their data through what they call a gender lens. And it means that epidemiological and clinical data that are funded by Canadian funding institutions have to be analyzed. They have to partition their data and analyze it. And so when they did this, in these papers, they reported that it was something about being female. It wasn't just about being pregnant, but that it was something about being female. And this was ignored in places including the United States. And so I want us to talk a little bit about some of the biological differences that I think might underlie why it is that women might suffer more severe diseases for some infectious diseases, including influenza. And I think it comes down to our immune system. And as a general rule of thumb, when we look at the immune response, whether it's to an allergen, whether it is to a virus, to a bacteria, a parasite, as we're going to hear, even a self-antigen, women tend to mount higher responses than males. And so I have this cartoon picture indicating just generically the magnitude of the response, and I am very virus-centric because of my training, so I have in my cartoon days after virus exposure, but I do think this is applicable beyond viruses, whether I see beyond viruses or not. When we look at activity of pattern recognition receptors, so things like toll-like receptors, which are very important for recognizing the presence of viruses, has been really nicely demonstrated with pattern recognition receptors, including toll-like receptor 7, activity being higher in females as compared with males and initiating a higher inflammatory or innate immune response. We even find there are beautiful data showing that macrophages from women are more effective at presenting antigen than are macrophages from males. Production of several inflammatory cytokines and chemokines, and I'll show data to speak to this in a moment. Typically higher responses in females as compared with males. That's why our pink curve is consistently higher than our blue. And this leads to greater activation of lymphocytes. So we tend to find greater activity of B cells, activation of effector T cells, including our CD4 and CD8 positive T cells, which ultimately leads to higher antibody production, which I think has been quite well characterized in terms of females having higher antibody production as compared with males. Less well characterized and often a bit more in the animal literature, but we do find higher activity of T cell responses. And so ultimately this likely is one mechanism contributing to how virus elimination or virus clearance by the adaptive immune response occurs more readily in females than males, and may contribute to why we see greater intensity of viruses in males as compared with females. So we might walk away from this thinking it's all good and we should all have the female immune system. But I want to emphasize something that I think Mark did a lovely job emphasizing, is that really for health there has to be some level of homeostasis in our immune system, and then if you have overactivation, or a dampening of any kind of anti-inflammatory or what I've listed here, regulatory type of response. It's going to regulate these inflammatory responses. This in and of itself can lead to pathology. So too much of anything is just that. It's too much. And so when we look at the induction of some of these regulatory responses, we often find, and we have data that have spoken to this, that you don't get a return to homeostasis as rapidly in females as you do with males. And so I hypothesize that this leads to an increased risk of developing consequences caused by, as Mark referred to it, an overactive immune response, or as I list here, a risk of immunopathology, when your immune system and the immune responses that you are mounting cause damage to tissues. In contrast, in males, having these lower responses, and in many cases, heightened regulatory responses, which we've shown in different systems in terms of TGF-beta responses and activity of things like regulatory T cells, while this can be beneficial for reducing the consequences associated with immunopathology, this can lead to an increased risk of viral persistence. We've shown this for hantaviruses. This has also been shown for some of the hepatitis viruses as well. And so I think what we don't have different immune cells, we don't have different pathways in place, we're responding with the same immune system responses, but the magnitude of these responses can differ, and that this can actually lead to differences in the outcome of infection and the consequences of infection. And so I just want us to kind of keep that in mind as we move through these data. So again, we work with mouse models. Primarily, I'll show some human data, but primarily mouse models. And so we've worked with a couple of different strains of influenza viruses, and just to kind of make the point that we try not to, as much as I care about the differences between the sexes, I try also to expand the pathogens that we look at so that we're not assuming that one pathogen is representative of an entire field. And so here we have data. What we're looking at in this slide are survival curves, okay, for males. Keep losing my males and females in response to 3 different mouse-adapted influenza viruses. PR8, which is an immunologist's favorite. This was an isolate from a Puerto Rican patient in the 1930s, so it's a little representative of the circulating strain of H1N1 from the 1918 pandemic. Then we have from the H3N2 pandemic in the 1960s, a mouse-adapted Hong Kong 68, abbreviated HK68. And then more recently from the 2009 pandemic, we have an H1N1 that's mouse-adapted as well. And so one of the first things that we do when we get a new virus in the lab is we do what are called LD50 curves. We determine the lethal dose that kills 50% of our animals. And one thing that we did that is never really done in the literature is we did this separately for males and for females for all our studies. We tend to work with C57 black 6 mice, and our animals are typically anywhere from 8 to 14 weeks of age when we work with them. This depends on whether we're doing surgeries and there's recovery time, but just in case I fail to mention that. And so for the non-mouse people in the room, 8 to 14 weeks of age, these are healthy young adults. They are well past puberty, so they are reproductively competent, healthy young adults, which I think will become important as we move through some of our data. And so, again, going from very high doses of virus to very low doses. For males, for females, you can see at low doses, just about everybody lives for males, even, to some degree for females. At high doses, just about everybody dies, and you can see that for each of these viruses. And so then from all of this, what we end up doing is we calculate that LD50, the dose that kills 50% of the animals. And I have that calculated for you on each of the curves. So for males, and then the corresponding dose of virus that killed 50% of the animals. For females, again, males, females, and what I hope you're seeing is that it takes a lot less virus to kill a female than it does a male. Okay, so the LD50 across all of these different viruses are consistently lower for females than they are for males. And what I find just remarkable is even if you go to a very high dose like we did in our most recent study with the 2009 mouse-adapted strain of flu, even at the highest dose where everybody dies, while there is no difference in the survival rates, when you look at the average day of death is still 2 days earlier for our females as compared with males. So, even when everybody dies, females are dying sooner than males. And just to show you what this kind of looks like, if we take, a moderately lethal dose, so we work with lots of different doses, but a moderately lethal, so this is 10 to the second TCID 50 units, comparing gonadally intact males and females. When we look at measures of morbidity, body mass, body temperature, females are doing worse. They're losing more weight, they're becoming more hypothermic, and when we look at survival, they're less likely to survive the infection as compared with males. Now, interestingly, despite what I told you at the beginning about the intensity of infection, which we joke about what our hypotheses are and then how your data just don't support that, we thought there would be sex differences in virus replication. And so, and let me just make a point that we often look within this first week after inoculation for a lot of our studies, because that's just before we start to see this divergence, okay? And so if we euthanize animals at different time points just after inoculation, and we extract the lungs, homogenize, and look and measure virus titers in lungs, we really find no difference. And you're going to see this pattern throughout my discussion, where virus replication, at least for our influenza model, is not really explaining the differences that we see in the outcome of infection. But when we looked at pro-inflammatory proteins, I have pictured here TNF-alpha, CCL2. We see something very similar when we look at interferon gamma, IL-6, where both males and females are mounting responses during that first week after infection, but it seems to be a bit excessive. You're talking about, in some cases, about 100-fold increase in females as compared with males over that first week, after inoculation. Well, so to speak to some work and make some consistency, so we've been very interested in what could be mediating these differences. And so based on a lot of the work that Dr. Rhonda Voskuil had published, we knew her collaborators and were very interested in looking at some of the genetic contributions to these differences that we were seeing between males and females. And so I'm going to let her expand on this model and describing this model of the 4 core genotype mice. But what these mice enable us to do is separate out chromosomal sex from gonadal sex. So as you can see, you could have an XY individual who is chromosomally XY but gonadally a female, or you can have an SeXX individual who is chromosomally a female but gonadally a male. And I will let her describe this, but I will only say that for flu, we really didn't find any clear-cut effect of sex chromosomal complement. If anything, we saw a trend in favor of a gonadal influence, that having the gonads of a female resulted in a sooner average day of death than gonadally being a male. So converging evidence in our system for gonadal steroids, if we take away the gonads of our males and our females, okay, so that's just the label GDX, so we take out the testes in males, thereby reducing testosterone concentrations to non-detectable levels. If we take out the ovaries in females, thereby reducing estrogen and progesterone concentrations to non-detectable levels, we eliminate our sex difference. Okay, so we see no sex difference in our measures of morbidity, including changes in body mass, changes in body temperature, and as you can see, their survival curves are they're very, very similar. Okay, so we eliminate the sex difference when we take out the gonads. So we then wanted to know, well, what's going on in our males? And I'll start with the males because it's a more clear-cut story. So when we compared gonadally intact males and gonadectomized males, inoculated them with our moderately lethal 10 to the second dose of TCID 50 units of PR8, and we looked at survival, we found that removal of the gonads significantly reduced survival in our males, and this was not due to differences in the virus titers. And interestingly, and I think related to a talk that's that we'll be hearing a little bit later this afternoon, when we looked at several different pro-inflammatory cytokines, effects on pro-inflammatory cytokines also did not appear to explain this difference. More recently, in working with a sublethal dose of virus so that we can start to move to later time points in our analysis of the immune system and immunologically what is going on in the immune system, we conducted a study in which we took out the gonads of both males and females, and to make this point that in our intact males, it's most likely testosterone mediating this protection. We compared gonadectomized males, some of which received placebo, so that's just these gonadectomized, and then gonadectomized males that received exogenous implants of time-release capsules of testosterone. So it continuously releases testosterone, and so here's our measure, bringing testosterone within the normal range for testosterone of young adult male mice. And what we find is that when we treat gonadectomized males with testosterone, and these are these closed symbols, we don't have any death in response to this sublethal dose of virus infection, but these males do not experience nearly as much morbidity, or in this case weight loss, as compared with their gonadectomized and not T-treated cohort. We've also developed, coming back to my behavioral neuroscience, a battery of tests that we use to generate a clinical score of sickness in these animals. And so when you look at this, we find that at that peak time of illness, our males that have been treated with testosterone, they aren't showing nearly the level of behavioral sickness as compared with their non-T-treated counterpart. If we opportunistically, so nobody died, so opportunistically out here at day 20, so well after virus has been cleared. So virus is typically cleared 10 to 14 days after inoculation. We just opportunistically took out the lungs, looked for virus. Virus had completely cleared, so below the limits of detection in our assay. But what we found when we looked at T cells was that way out here, long after virus has been cleared, males that have been T-treated as compared with their gonadectomized counterparts have significantly lower numbers of total. And so tetramer just means that these are virus-specific CD8 positive T cells in their lungs. So we have more of these virus-specific T cells still in the lungs of our gonadectomized males way out here at day 20. We also find that these cells produce we have more of these TNF-alpha, so these pro-inflammatory cytokine-producing T cells in response to virus stimulation ex vivo. So the cells make more cytokine in response to stimulation, and this is reduced in males that are treated with testosterone. And so we now finally have money to kind of go back and look at some of these earlier time points to look at the evolution of this response or the kinetics of this response to see if, in fact, treatment with testosterone helps maintain the kinetics so that you're getting the increase in these virus-specific T cells at the time when virus is present in the lungs, and then you get this turned off, whereas in these gonadectomized males, as we're hypothesizing, there might be some dysregulation, and so you're not getting the turning off of this response the way you would hope. And just to note, because I know we will be talking about this a bit later, when we looked at neutralizing antibodies, again, just at this single time point, so we haven't gotten into the kinetics of this, we did not see effects of testosterone. So like I said, we've done a lot of our work in individuals of reproductive ages, and I think it's rather interesting to look at some differences that occur when we look at individuals of reproductive ages versus individuals after, or during, if you will, reproductive senescence. So individuals, and so in the flu literature, I think in the vaccine literature in particular, there's something that we think happens at the age of 65, because you often see this categorization of individuals of being 65 years and older. So that's kind of why I make that designation there. And so when we look at individuals 65 years and older, if we look in unvaccinated populations, we find that in contrast to what I presented to you about younger adults, so that's 16 to 45 age range, we find that in individuals 65 years and older, it's men who are more likely to be hospitalized. And a lot of this, again, is in seasonal influenza epidemics. They're also more likely to die. Even though what I do find interesting is that rates of vaccination are in fact higher among older men than women. And as we'll be talking about a little bit later in my discussion and in subsequent discussions, antibody responses are still higher among older females as compared with males. And so one question that we have about this concept of older males suffering more disease among unvaccinated individuals. So we've wondered, is low testosterone contributing to this at all? So just to kind of show you again in our animal model, comparing young and older male mice. So young are 2 month of age mice at the time that we begin our studies. Older mice are 18 months at the time that we begin these studies. And yes, I am working with somebody who has funding from the National Institute of Aging so that I can afford these very expensive old mice. They are very expensive if you don't have funding through their institute. So what we were able to show is that, is that consistent with what's known in the influenza literature, younger individuals do in fact recover from influenza. And again, this is a sublethal dose of the virus. And you can see we typically run our studies for 3 weeks. And even at the end of this 3-week period, the older males still had not reached baseline, which is this stippled line that we see right here. So you get greater morbidity. Again, in terms of that clinical behavioral story, you get greater behavioral sickness in our older males as compared with our younger males. They do start at a different baseline, but even if we were to account for that, that we see more behavioral sickness. Again, we see a decline in testosterone. So these males that are 18 months of age have lower testosterone concentrations as compared with our younger males. And we also find that, again, opportunistically, nobody died, so we took out the lungs. Again, virus was not detectable, so I don't even have anything to graph and show you at this late time point. But we did find that older males have higher total virus-specific CD8 positive T cells in their lungs, as well as cells producing TNF alpha following ex vivo stimulation with influenza virus antigen. Now here we did see an interesting effect, again, single time point, so it's hard to draw conclusions about the kinetics of something, but lower antibody responses in our older males as compared with our younger males. And so what I found remarkable was that when we looked at the profile, in particular of the T cell responses, our older males looked very similar, immunologically speaking, to our young gonadectomized males. So they have lower testosterone, higher CD8 positive T cell responses at these later time points. And so again, now that we have money, we're going back and we're going to be looking at the kinetics of what's going on with the generation of these T cell responses and how testosterone might be contributing to that. Well, so not to leave out the females turned out to be a more complicated story because as I discussed in some of my meetings with folks this morning, what you do when your data don't support your pet hypothesis. And so when we observed that gonadally intact females had reduced survival, we hypothesized, so for the trainees in the room, that if you took out the ovaries of our females, this would in fact make them better able to survive infection. And as you can see, that is not what we observed. There were no differences in these curves, even though there is a slight difference at the end. There's no difference in either the survival rate or in the average day of death between these two groups. We also saw no difference in virus titers over that first week. So again, just prior to where we start to see death in this particular model. And so we were really kind of left wondering what might be going on. We measured estrogen, progesterone. We published this at different time points, doing single time point sampling of cyclical hormones, especially if you don't have really kind of fancy sensitive methods. It really wasn't giving us a lot of information. So going back to my days in behavioral neuroendocrinology, I knew a lot about the mouse reproductive cycle. So it's called the estrus cycle, and females cycle through 4 stages of the estrus cycle: estrus, medestrus, diestrus, and proestrus. And we know a lot hormonally about what's going on, both with regard to estradiol, but also progesterone during each of these stages. So what we decided to do was, knowing how sick these animals get in response to flu, and knowing that sickness and the activation of various brain circuits leads to all kinds of changes in hormonal pathways, regulating glucocorticoids, but also regulating sex steroids. We really started to think, is a gonadally intact female, is she really characteristic of a gonadally intact female following infection, or could it be that she's showing some level of reduction in her sex steroid hormones, was what we were trying to get at. And so what we did was we monitored the estrous cycle of females prior to infection and then after infection, and what we found is that after infection there was a significant lengthening of the estrous cycle, and this was solely due to an increase in the amount of time that females were spending in this stage called diestrus when both estrogen and progesterone levels are low. And so we use this to speculate that infection may actually be causing persistently low levels of both estradiol and progesterone in gonadally intact female mice. And what I think becomes important here is that estradiol can actually have bipotential effects, in which at low levels, estradiol can actually be pro-inflammatory, but at higher circulating concentrations, estradiol can actually be anti-inflammatory. So we then wanted to know, well, if we went in and we normalized estradiol concentrations exogenously in females, what would this do to the outcome of infection? So we took out the ovaries of our female mice, and in half the females, they received placebo, and in the other half, they received time-release capsules filled with estradiol that brought estradiol to the high end of the physiological range. And what we found was that treating with estradiol significantly protected these females. So here, just as a measure of morbidity, looking at body temperature, we did not see the level of hypothermia that is often associated with death. They were better able to survive, and obviously the average day of death was significantly lengthened for our females that were treated with estradiol as compared to those not treated. But again, when we looked at virus titers at several time points during that first week after infection, there was no effect of estradiol treatment and in this study either. So you're seeing that we're not really seeing effects of either sex differences or effects of hormones on virus titers. We've also looked at characteristic cytokines like type 1 interferons that are associated with being able to reduce virus replication, and we do not see sex differences in the system there either. But when we looked in our estrogen-treated or estradiol-treated compared with our non-estradiol-treated at several different pro-inflammatory and anti-inflammatory cytokines and chemokines, some very interesting profiles emerged. And so we've looked and done the kinetics just for the ease of viewing these data. I'm only showing you what's going on 7 days after inoculation with the virus because I think it just makes the point quite nicely. And so what we consistently find is that when we treat females with estradiol, we significantly reduce a lot of the pro-inflammatory cytokines that are associated with immunopathology during influenza virus infection, including tumor necrosis factor alpha, interferon gamma, IL-6, and the chemokine CCL2, which is very important for the recruitment of monocytes as well as different populations of dendritic cells into the lungs, all of which have been associated with immunopathology. And I'm realizing that I may not have even mentioned to you all that one of the current hypotheses or the prevailing hypothesis for why people die from severe influenza, rather than it being caused by out-of-control virus replication, it really is thought to be this immunopathology, this inflammation or this inflammatory response that we mount in response to infection, and that's what's contributing to pulmonary damage and death. And so here we're showing that many of these cytokines that have been at least correlated with adverse outcome, even in humans, are being downregulated by estradiol. But it wasn't to say that estradiol was downregulating everything. Several chemokines, including CCL3 and SeXX, were both upregulated. And what really struck us here is that these are chemokines that are very important in the recruitment of neutrophils. So because we were seeing some interesting patterns in chemokine responses, we decided to look at the recruitment of innate immune cells into the lungs over the course of that first week following inoculation in females that were ovaryectomized and treated with placebo or ovaryectomized and treated with estradiol. And basically, we looked at lots of different cell populations, and it came down to our neutrophils. So we defined these neutrophils as being CD11C and MHC class II negative, but CD11B, Ly6G positive, so it's this population for any of the non-immunologists in the group. And so just showing you, again, naive, no difference between our estrogen-treated and non-estrogen-treated, but when we looked at day 7, we see a lot more of these cells, and you can see this graphed here. So really, over the time course of infection, it's really out here at day 7 that we really see this dramatic increase. And neutrophils are turning out to be such an interesting cell population that really is at the junction between protection and pathology. They're important for that induction of inflammation, yet they're also important for that resolution of inflammation. And so these data are currently in press at the Journal of Virology, and what we've been able to show is that if we treat females that have been exposed to estradiol with an anti-Ly6G antibody, so we can neutralize the influx of these neutrophils, we can reverse the protection. So we really think neutrophils are kind of central to the story that's developing for us. The way that estradiol and that higher levels of estradiol can have their anti-inflammatory effects is by binding to the estrogen receptor located in the cytoplasm of the cell. So estradiol is in fact lipophilic, and it's actually been shown to be able to suppress the activation of a transcriptional factor, NF-kappa B, to result in a reduction in the production of inflammatory cytokines and a reduction of inflammation. And so we can use select ligands for either estrogen receptor alpha or estrogen receptor beta in an effort to see which pathway or activation of which pathway most closely mimics the effects of estradiol. And so we have done that using ligands specific for estrogen receptor alpha, which is abbreviated PPT here. This is our closed heel, as well as an estrogen receptor beta agonist, abbreviated DPN. And what we find is that when we compare these groups with additional groups of females, all of whom have been ovariectomized, placebo-treated here, estradiol-treated here, females that have been ovariectomized and treated with the estrogen receptor alpha agonist most closely mirror the estradiol-treated females, so we see increased survival. So I am going to move it along so I can get to vaccines in my last 5 minutes. So we do see, so again, estrogen receptor alpha signaling involving neutrophils and possibly CD8 positive T cells is kind of where we're going with our estrogen story. I'm going to go back one, so I may end up going over just 1 minute. I want to make because I want to make one point with you. While we see that these anti-inflammatory effects of either testosterone or estradiol. I was even asked questions about progesterone. We have a progesterone story developing in the laboratory now, but again, anti-inflammatory, protective when it comes to the outcome of infection. I don't think that these anti-inflammatory effects of sex steroid hormones are always going to be protective. I think it depends on the system that we're studying. And so these are our data from my laboratory working with a different system. Here we were working with human papilloma virus-like particles, which are the basis for the HPV vaccine. And we were interested in the responses of cells isolated from women. So these were healthy women who were not on any oral contraceptive or hormone replacement therapy. These were all regular cycling women. We collected blood during the follicular phase of their menstrual cycle, isolated the peripheral blood mononuclear cells, so these PBMCs, and we stimulated them with this human papilloma virus. These VLPs are what they're referred to. And so here you can see that when you stimulate these cells with these VLPs, you get really a dramatic activation of inflammatory cytokines by these cells. So here's medium alone, here you can see, and we even get activation of a lot of anti-inflammatory cytokines. So it's a very immunogenic stimulus. And these induction of these inflammatory responses really are thought to be very important for induction of the downstream adaptive immune response. And so if we put on these peripheral blood mononuclear cells at the same time that we give these HPV VLPs, different concentrations of estradiol, abbreviated E2, or progesterone, abbreviated P4, either alone or in combination, the take-home message from this is that when we compared this with cells that just got exposed to the HPV VLPs alone, and we looked at the concentration of several different anti-inflammatory cytokines and chemokines, as well as pro-inflammatory, and we looked at relative cytokine production, again, relative to these cells that were not exposed to hormone, what we found is that exposure to estradiol or progesterone, either alone or in combination, increased the production of these anti-inflammatory cytokines. Okay, it increased production of things like TGF-beta, IL-10, IL-1 receptor antagonist. So we got more of an anti-inflammatory profile in cells that were exposed to these hormones. So very similar to what I've been telling you in our mouse model with flu, but here the induction of these anti-inflammatory responses may not be beneficial to the responses to the vaccine. So whether we interpret anti-inflammation as being good or bad, I think really depends on the system and the context in which we're studying this. Okay, so now in my last few minutes, let me just talk to you a bit about viral vaccines. So I've introduced the concept of vaccines to you through our HPV work, but in the human literature, there are a lot of studies showing that responses to the influenza vaccine, measles, mumps, rubella, hepatitis, a herpes virus a vaccine trial that was so interesting, yellow fever, human papillomavirus, an HIV clinical trial, and then you can read the rest. When we look at the humoral immune responses, which for each of these different vaccines are thought to be the relative correlate of protection, we find that females consistently have higher antibody responses as compared with males. Okay? I'm going to go ahead and skip this because I think this is going to get covered in a moment. And just, again, in my last few minutes, to point out that when we look in response to the influenza vaccines, this is the trivalent inactivated vaccine, the one that we get intramuscularly. What I love about this particular clinical trial is they looked at responses to both a full dose of the vaccine and a half dose, because you could really get me going if you wanted to talk about sex-specific dosing of vaccines. What I find very interesting is that in both cases, females have higher antibody responses as compared with males. And when you look at and these are kind of individuals 18 to 49 years of age. When you look at the response of females to the half dose, it's just about identical to that of males with a full dose. Consistently, and what's been also noted, kind of the downside. So the upside, you've got these higher antibody responses. The downside, you get greater reports of adverse reactions associated with inflammation, injection site pain, muscle pain, headache, and even inflammation. The prevailing hypothesis in the literature is that it might be a gender difference. Women might be more likely to report these types of adverse reactions as compared with males. But again, I might argue that an alternative hypothesis may be that if you have higher inflammatory responses in females, it might be greater inflammation at the time of vaccination that could also be contributing to some of these adverse effects. We can recreate this using live virus immunizations in our mice. So whether we immunize with an H1N1 or an H3N2 virus, both of which I've introduced you to already, measure antibody responses. The kinetics of these antibody responses can differ depending on the virus, but we've looked out as far as 42 days after vaccination, and we find that females consistently mount higher antibody responses as compared with males. If we immunize animals with a virus, so in this case an H3N2 virus, measure antibody higher in females, and then infect with a lethal dose of the virus that they were immunized against, we find that even though males have lower antibody responses, the responses they have must be enough because equally protected, both males and females, when we challenge them and look at morbidity. Where something interesting happens, and I think this might involve T cells, so it might be something that Mark and I need to speak more about. If we immunize animals with an H3N2, or we can reverse this. It could be the H1N1. We've done this and we've published it both ways. Measure antibody, again, higher in females. If this time we go back and inoculate with a lethal dose of a virus that their immune system had not previously been exposed to. So this is a virus, an H1N1, that has different outer proteins, but internal proteins, which can involve recognition of the T cell by T cells, are in fact highly conserved. But when we look at morbidity as well as virus titers, what we find is that when we look at this cross protection, that's where we find that females do better. They're better at cross protection. They don't experience nearly the amount of morbidity as compared with males, and in this case, they clear virus significantly faster than their male counterparts. Okay, so just again, I think there is this age by sex interaction. I don't think I want anybody to walk away going, with regard to flu, it's always females who suffer more disease. That seems to be true during our reproductive ages, and at later stages, it actually seems to be males who are suffering worse disease. Again, paradoxically, young adult females, they may suffer a worse outcome from infection, but if you vaccinate these individuals and then expose them to the viral infection, they do appear to do better. Heightened inflammatory responses, I do think this is a bit of a double-edged sword for females. I think you need these responses to initiate these adaptive responses that are going to be necessary for clearance and recovery from infection, but if these responses become too high, then this can actually contribute to some of the tissue damage. I showed you that sex steroid hormones regulate immune responses. Both testosterone and estradiol appear to be anti-inflammatory, but possibly through distinct pathways. And lastly, just that this concept that the cost and benefits of immunomodulation by sex steroids, I think it's different depending on whether we're looking at the outcome of infection or vaccination. And so with that, I will end, and I thank you for your time, and I apologize for going over.
Take a couple questions.
Okay.
Are there any questions?
Yes.
When you looked at the response to NK cells and Tregs, have you explored the actual signaling of testosterone as you have with estradiol?
So I'll repeat the question. The question was whether we have looked at natural killer cells or regulatory T cells, and whether we have explored more of the mechanistic pathways in testosterone the way we have with estradiol. So we have not looked at natural killer cells. The only time we've looked at natural killer cells was in our estradiol study, and we at least saw no differences in the recruitment of numbers of natural killer cells, but it's not to say that activity might not differ. And there are studies indicating that hormones do in fact influence the activity of natural killer cells, and we have not looked at that. For regulatory T cells, we have not seen we actually saw no effect of testosterone, at least at that late time point. So we were kind of going backwards now that we have money, and we are looking at CD4 as well as CD8 T cell populations. And the reason I only showed you the CD8 T cell data is because that's the only place we saw differences. We didn't see differences in any of the, at least in terms of numbers of FOXP, and we didn't get into a lot of the nuances. These were just basically FOXP3 positive, CD4 positive T cells. We did not see an effect of testosterone. We also have not seen an effect of either estradiol or progesterone, at least on numbers of regulatory T cells. Again, in my other life, when we were working with hantaviruses, we did in fact find higher numbers of regulatory T cells in males as compared with females during infection. So that would be a place where we have seen some differences. And that's kind of an interesting virus where rather than it causing an acute infection, it causes more of a long-term persistent infection. So I might argue that some of the regulatory T cell activity may be most important. And I think this is true even for some of the hepatitis virus data, where regulatory T cells are really important with their activity, often correlating with increased persistence of viral infections. And then lastly, no, we are just now moving into testosterone, so we have not done nearly the amount of work. Yes.
Excellent presentation. There's a huge group of women who have been treated for early breast cancer with anti-estrogens. That would be a very fertile group to look at the effect of estrogen levels and influenza and vaccination. Have you thought about that?
I absolutely have. But we have not yet kind of found investigators. It's interesting, one thing I have actually run up against, this is true with regard to breast cancer patients. This is true with regard to autoimmunity patients, is a lack of desire to accept the influenza vaccine. So it's a very, this kind of gets into a heated discussion for me because I am definitely think that people should be getting vaccinated. But so kind of I don't have a lot of support from different colleagues adding in vaccination into their...
Do they get worse flu?
That's a good question, and I don't know. I can tell you that I started some work with actually one of Dr. Rhonda Voskuil's colleagues at Hopkins, Peter Calabresi, who noted that on certain drug treatments, some of his multiple sclerosis patients were coming in with at increased rates with upper respiratory infections, including influenza. And so we've done some mouse work to look at how some of these drug treatments affect the outcome of flu, and they do appear to make it worse in mouse models. But, so it is kind of interesting, these connections. They're ignored too often. But some really interesting data with some of these breast cancer drugs, fertility drugs, reducing virus titers. And this has been shown for Ebola, which is kind of interesting, in a variety of cell lines. That's published. And more recently, I've seen some discussions with HIV that viral load can be reduced by treatment with some of these estrogen receptor modulators. So some exciting work. Okay. Oh, thank you so much.